Is the serum angiotensin-converting enzyme ACE level useful for the diagnosis of sarcoidosis? What about serum lysozyme? The serum ACE level is elevated in 40% to 90% of all patients with sarcoidosis. Elevations correlate with active pulmonary disease and can normalize with therapy. This enzyme is produced by epithelioid cells and alveolar macrophages at the periphery of granulomas in response to an ACE-inducing factor released by T cells. Elevated ACE levels are not specific for sarcoidosis. Other diseases in which ACE levels can also be elevated include tuberculosis, coccidioidomycosis, Gorka's disease, hypersensitivity pneumonitis, silicosis, asbestosis, leprosy, hyperthyroidism, lung cancer, and diabetes mellitus. Additionally, there are genetic causes of ACE levels due to ACE gene polymorphisms. Therefore, an elevated ACE level may be supportive, especially if greater than 2 times upper limit of normal but not diagnostic, of sarcoidosis. Of note, ACE inhibitors can suppress the serum ACE level. The serum lysozyme level is elevated in 70% to 80% patients with sarcoidosis. It can be elevated when the ACE level is normal. Elevations correlate with the extent of sarcoid organ involvement and can normalize with therapy. This enzyme is secreted by monocytes and neutrophils. Elevated lysozyme levels are not specific for sarcoidosis as there are multiple other diseases that can cause an elevation. Similar to ACE levels, it can be supportive but not diagnostic of sarcoidosis. What is Lofgren syndrome? What is Herford syndrome? Lofgren syndrome is a triad of acute arthritis, periarthritis, erythema nodosum, and bilateral hilar adenopathy in a patient with sarcoidosis. This can be associated with fever and uveitis 6%. Joint involvement most commonly presents as an arthritis and/or periarthritis of the ankles. The acute arthritis is usually self-limited and resolves within weeks but may persist for months, average 3 months. Nonsteroidal anti-inflammatory drugs are recommended initially, but low-dose corticosteroids may be clinically necessary to manage if severe symptoms exist. The ACE level is elevated in less than half of the cases. However, those with an elevated ACE level are more likely to have recurrence or persistence of the arthritis. Overall, these patients have a greater than 90% remission rate. Acute histoplasmosis may simulate Lofgren syndrome and must be excluded by serologies, urine antigen, and cultures. Herford syndrome, uveparotid fever, is a combination of fever, parotid enlargement, uveitis, arthritis, and facial nerve palsy. It occurs most commonly in males and usually has a poor prognosis. Moderate-dose corticosteroids and chronic immunosuppressive therapy are typically necessary to manage clinical manifestations. How does skeletal muscle sarcoidosis present clinically? Sarcoid myopathy typically occurs in patients with multi-organ involvement. Although muscle involvement in sarcoidosis is usually asymptomatic, there are 3 clinical presentations: nodular, acute myocytic, and chronic myopathic. The nodular presentation is the least common type, involving the musculotendinous junctions and demonstrating a dark star pattern on muscle magnetic resonance imaging (MRI). Acute granulomatous inflammatory myositis is rare, occurs mainly in African American women, and is indistinguishable clinically from polymyositis. Chronic myopathy is the most common form and is manifested by an insidious onset of proximal symmetric muscle weakness and wasting. Neurogenic atrophy due to granulomatous infiltration of nerves can occur. Muscle enzyme levels, electromyography, and muscle biopsies are necessary to differentiate the different types of muscle involvement. The acute myositis will respond to corticosteroids, whereas the nodular and chronic myopathic forms are less likely to respond. What osseous changes occur in patients with sarcoidosis? The overall incidence of osseous sarcoid is reported in 3% to 13%, although this may be underestimated. Bony lesions are associated with chronic overlying cutaneous lesions and multi-organ involvement. The phalanges of the hands and feet are classically involved, but with more frequent use of advanced imaging techniques, axial bone involvement is more commonly reported. The metacarpophalangeal joints, metacarpals, and wrists are usually spared. Typical radiographic findings include trabecular pattern, osteolysis, or cysts, punched-out lesions. Bone scans, MRI, and fluorodeoxyglucose positron emission tomography scans may detect unsuspected osseous involvement, since over 50% of bony lesions are asymptomatic. Can sarcoidosis and other connective tissue diseases coexist? What other diseases? Several reports have described sarcoidosis in patients with other rheumatic diseases, including systemic lupus erythematosus, rheumatoid arthritis, systemic sclerosis, Sjogren's syndrome, polymyositis, spondyloarthropathies, systemic vasculitis, and inclusion body myositis. However, the diagnosis of sarcoidosis and connective tissue disease must be made with caution. Sarcoidosis can mimic clinical and laboratory manifestations of other rheumatologic diseases, and conversely, the connective tissue disease may cause granulomatous inflammation. Medication-induced sarcoidosis has been described following therapy with immune checkpoint inhibitors, highly active antiretroviral therapy, IFNs, and TNF-alpha antagonists. How is sarcoidosis usually treated? Most patients with sarcoidosis do not require therapy. In patients with critical organ involvement, multi-organ disease, or symptoms that significantly affect quality of life, corticosteroids remain the first-line treatment. The exact dosing strategy that balances the desired effect and side effects of corticosteroids is less clear. Oral corticosteroids, up to 1 mg per kilogram per day, are used as first-line treatment for symptomatic and progressive stage 2 and 3 lung disease, malignant hypercalcemia, and severe ocular, neurologic, cardiac, and skin involvement. The dose is typically tapered to 10 mg per day by 6 months and maintained on 10 mg per day for an additional 6 months before tapering further. If the patient continues to have progressive disease, or cannot taper the prednisone to less than 10 mg daily, additional immunosuppressive therapy is indicated. Patients with severe cardiac or neurologic involvement may benefit from additional immunosuppressive medication when corticosteroids are started initially. Methotrexate at doses of 15 to 20 mg weekly is the most commonly used steroid-sparing agent for both pulmonary and extrapulmonary involvement. Azathioprine 2 mg per kilogram per day, leflunomide 10–20 mg per day, and mycophenolate mefetyl 1000–15,000 mg twice a day have also been reported as effective. Failure to respond to at least one immunosuppressive, disease-modifying antirheumatic drug plus prednisone is an indication for treatment with anti-TNF-alpha agents, which can be effective against infiltrating non-casseting granuloma. Not all anti-TNF-alpha agents are equally effective in sarcoidosis. Infliximab 5 mg per kilogram every 4 to 6 weeks, or adalimumab 40 mg subcutaneous weekly, is recommended. Etanercept appears to have limited benefit. Chloroquine, hydroxychloroquine has been used for cutaneous or musculoskeletal involvement. Cyclophosphamide, oral and intravenous, has shown benefit in patients with cardiac or neurosarcoidosis. In case reports, rituximab has been used successfully for refractory disease, particularly when granulomatous mass lesions are present. Implantable pacemakers are inserted in patients with cardiac involvement and arrhythmias or heart block. Solid organ transplantation can be life-saving in patients who have failed all medical therapies. Patients must be monitored for side effects and prophylactic measures used to prevent toxicities. Patients on high-dose corticosteroids should receive prophylaxis against pneumocystis jirovecii. Osteopenia and osteoporosis due to dysregulated calcium metabolism and medications used in therapy can occur in up to 2/3 of patients. Vaccinations should be kept up to date. Depression is common, 46%–66%, and should be screened for and treated. Fatigue is common, 50%–70%, can be disabling, and may respond to armodafinil or dexmethylphenidate. Hypothyroidism, hypoxemia, depression, and sleep apnea are potential and correctable causes of fatigue. How is osteoporosis treated in patients with sarcoidosis? Hypercalcemia 5%–25% and hypercalcuria can occur in patients with sarcoidosis due to increased activity of the 1-alpha-hydroxylase enzyme in granulomas, leading to increased 1,25-dihydroxyvitamin D calcitriol. This can lead to nephrocalcinosis and renal dysfunction. Patients may have a high calcitriol level despite a low 25-hydroxyvitamin D. Osteopenia and osteoporosis are well-known adverse effects of corticosteroids, and sarcoidosis can also cause direct bone lesions with subsequent bone loss. All sarcoidosis patients on corticosteroids or who are postmenopausal should have bone density measurements. Bisphosphonate therapy can be started in those at risk for fractures. However, calcium and vitamin D supplementation should be used with caution and monitored closely, since sarcoid patients are prone to develop hypercalcemia and hypercalcuria. Discuss the prognostic factors in sarcoidosis. The extent of organ involvement in most cases is defined at presentation, with less than 25% of patients developing new organ involvement within 2 years of follow-up. Most patients, 60%, undergo spontaneous remission with an additional 10% to 20% resolving with corticosteroid therapy. However, in 10% to 30%, the course is chronic. In general, the more severe the involvement and the more organ systems greater than 3 involved at the time of diagnosis, the worse the prognosis. African American race, disease onset after age 40, symptoms lasting over 6 months. Advanced radiographic stage pulmonary disease, pulmonary hypertension, and extrathoracic involvement cardiac. Neurologic, lupus pernio, panuvates, hypercalcemia, and bone are poor prognostic signs. Overall mortality is 5%, with half dying of progressive pulmonary disease and half dying of cardiac or neurologic involvement.